Welcome everyone. Good evening. This is our 5th episode of the fall 2020 season of UT Southwestern Science Cafe, and we are so glad to see everyone, our regulars and guests. I'm Jenny King, and I'm Director of Public Affairs here at UT Southwestern. On behalf of my colleague, Corey Tobian, and our fabulous guest speaker, Dr. Aditya Bagrodia, thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dive science topics. The format's casual and interactive, and we have both UT Southwestern faculty and occasional invited special guests as your speakers. Please do ask questions and engage with us during the program. This evening, in recognition of Men's Health Awareness Month, we will be discussing precision medicine, the science of men's health. Thanks in advance to Assistant Professor Dr. Aditya Bagrodia for joining us tonight. Bagrodia will take us on a deep dive into precision medicine health, including biomarker profiles, disease risk prediction, and the molecular characterization of tumors. Those are a lot of big words. Before we begin, as usual, there are always technical matters we have to mention, so here we go. First of all, recording this program and live streaming it on the UT Southwestern Twitter page. We wanted you to know that. Please go ahead and mute your microphones to help with audio clarity for everyone, and just unmute yourself called on to ask a question. And again, we do encourage you to ask questions. Please use the chat feature to do so. We will call on audience members to ask their questions following their joint presentation. His presentation. Finally, Corey is facilitating Q&A. And just a reminder, we cannot answer personal medical questions, but we would love to hear from you with general questions. And I am so pleased to introduce our presenter. As mentioned, it is Dr. Aditya Bagrodia. He is an assistant professor in the Department of Urology here at UT Southwestern Medical Center in Dallas, where he is a Dedman Family Scholar in Clinical Care. Dr. Bagrodia's clinical practice focuses on treating all urologic malignancies, including adrenal, upper tract, renal, bladder, prostate, penile, and testicular cancer. He has expertise in complex multidisciplinary management and minimally invasive approaches to surgery. Dr. Bagrodia has conducted extensive research in urologic oncology, primarily in biomarker profiles and molecular signatures of urologic tumors as predictors of clinical outcomes, and his research is funded through grants from the Cancer Prevention and Research Institute of Texas, which is CPRIT, and the National Institutes of Health. And just a point of note, CPRIT is a really exciting funding source. We are the second largest funder of cancer funding research for the United States, and that is paid by your taxpayers for the services. Dr. Bagrodia, welcome to Science Cafe. The virtual program is yours.
All right, thank you so much, Jenny. I'd like to first off thanks Jenny and Corey for inviting me, and the administrators of the Science Cafe program, and certainly want to thank all of you all who are spending some time this evening to talk a little bit about men's health and learn about some of the exciting things that we're doing here at UT Southwestern. So without further ado, I'll jump into it. And so just a brief word about men's health. So November is known as Men's Health Awareness Month. And this was a movement that was started out in Australia, actually. A bunch of Aussies decided they would shave themselves clean on Halloween, October 31st. And over the course of November, they would grow mustaches. And when people asked them why they were doing this, they would, use it as an avenue to raise awareness for men's health. And over the last couple of decades, it really has grown into a very organized and powerful organization. And it's the only global charity solely dedicated to men's health issues. And specifically, the November Foundation focuses on 3 areas of interest, including prostate cancer and testicular cancer. These are clearly near and dear to my heart, cancer types that I treat on a daily basis, as well as men's mental health. And I wanted to start out by just kind of giving you a sense of the scope of these men's health issues. Starting out with prostate cancer, it's a very common cancer. Almost 200,000 new cases of prostate cancer in the United States annually. And ultimately, about 1 in 9 men will be diagnosed with prostate cancer during their lifetime. Every year, about 33,000 men die from prostate cancer in the United States. And you'll notice here that of the 200,000 new cases, there are 33,000 deaths. So fortunately, the vast majority of men being diagnosed with prostate cancer don't die. And we'll touch base on this fairly extensively and how and who we want to treat, who we can potentially withhold treatment from, and who we need to be very aggressive with. Ultimately, about 1 in 41 men will die of prostate cancer, and it's the second leading cause of cancer death in men within the United States. Again, it is a highly curable malignancy, fortunately, due to widespread screening, and over 3 million men are alive in the United States with prostate cancer today. The second prong of the Men's Health Awareness Month is testicular cancer. And there are about 10,000 new cases of testicular cancer in the United States annually. Now, not nearly as common as prostate cancer. Nevertheless, about 1 in 250 men will be diagnosed with testicular cancer over the course of their life. And about 440 people die of testicular cancer annually. So again, you'll see here that out of the 10,000 cases, there's 440 deaths. And testicular cancer is a model for a curable cancer. With expert multidisciplinary care, fortunately, the vast majority of men are curable. Testis cancer tends to affect men between the ages of 15 and 40. It's the most common cancer in that demographic. And because it is so curable, in addition to making sure that we maintain those excellent cure rates, it's also paramount that we do everything possible to make sure that the interventions that we offer, whether that's surgery or chemotherapy or radiation, aren't negatively affecting men for the remainder of their lives. As I mentioned, it's the most common cancer in young men, and it's responsible for more life years lost than any other non-pediatric cancer. Then finally, some statistics about men's mental health. This is stuff that I learned as I was preparing for this talk. I didn't realize the scope of the problem. The age-adjusted suicide rate in 2018 was 14 per 100,000 individuals. The rates are highest among middle-aged white men. And in 2018, men died by suicide about 3.5 times more frequently than women. On average, there are 132 suicides per day, and white males accounted for approximately 2/3 of these. Firearms were involved in about half of these suicide deaths. So I just wanted to, start off by giving you a sense of the scope of some of the issues, some of the pressing issues that face men's health. Now, I was thinking about preparing for this talk, and I know it's an audience of patients, of physicians, of scientists, of lay people. And when I was reflecting on what I do on the day-to-day, a lot of it is really just balancing uncertainty, risk, and insurance. And to start with, in terms of insurance, I thought I would just look up Webster's dictionary definition. And Webster states that insurance is a means of guaranteeing protection or safety. And as cancer doctors, I think we're trying to keep our patients safe and protected. When I think about insurance, though, it's kind of like paying for something you hope you'll never use. We do plenty of things. And how valuable is insurance? Well, if you look at some, basic statistics, the average annual cost of health insurance for a family is about $20,000 per year per family. The cost of car insurance is almost $1,500. The cost of home insurance is $1,300. So on average in the United States, we're spending about $25,000 per family on insurance. And I would say that, by definition, this is something that's considered valuable to people in the United States. And when it comes to measuring, judging risk and uncertainty, I don't think we do a very good job. Here is a quote from the manager of statistics at the National Safety Council. And he states that human beings, we just are not good at estimating our own risk. We tend to fixate or focus on the rare or startling events. And I would posit that that's probably true. And I'll pause briefly for some poll questions. Now, these are kind of rhetorical, but spend a moment to think about them as Corey pops them up. Did you eat today? Did you drive today? Did you go for a walk? You get nervous about going on flights. You get nervous about going swimming in the ocean. So I'll give you just a few seconds to put in an answer. I'll put mine in as well. Okay, so hopefully we've had a moment to answer. And when we look at, so here are some results. If you're not able to see them, most people ate today. The majority of folks drove. Most people went for about 2/3 of people went for a walk. 1/3 of people get nervous about flights, and half of the group gets nervous about going swimming in the ocean. And the reason I just kind of ask these questions are, you can actually look at what are the lifetime risks of dying from common causes. Motor vehicle crashes, so car accidents, 1 in 100. That's pretty. Pedestrian incidents, 1 in 540 people will die in a pedestrian incident. Choking on food, 1 in about 2,500 people. Airplane accidents, 1 in 11 million. So these are, relatively low probability events, but about half the people said that they get nervous going on a flight. Shark attacks, Jaws really did it for the sharks, and only a 1 in 265 million chance of getting injured or killed by a shark. And this just kind of gives us a flavor. Of course, eating and so forth, that these are mandatory things that we have to do, but I think it highlights that oftentimes our ability to objectively assign risk is difficult. And when it comes to cancer care, absolutely, we are managing risk and uncertainty. And risk is defined as where we must make a decision for which the outcome is not known with certainty. We don't know exactly what we're going to get. However, all possible outcomes and probabilities can be assigned. So we can give you a reasonable flavor of what to expect. Uncertainty, in contrast, we cannot list all the possible outcomes. We don't exactly know what's coming, and you cannot assign probabilities to all the outcomes. To make an informed decision becomes significantly more difficult. And when you think about it, human evolution, every second of every day is in some form or fashion making assessments about, is this safe? Is this risky? Is this worth it? And again, we do this in minute decisions that we make on the day-to-day, and we do it on a larger scale. Like, for instance, do you prefer a new or a used car? You're incorporating some amount of risk. Do you have a large, small social circle? Do you like trying new foods? Do you like going to different places for vacations? Maybe in some real life examples. Would you fly today in the context of the current pandemic? Would you go out to eat at a restaurant? And I'm guessing that everybody has different metrics for what they think is safe and what they think is risky. And it's not exactly black and white. There's varying degrees about knowledge regarding the outcome, and there's varying degrees about knowledge and the likelihood of an event. And when you've got a decent understanding of the outcome, the decent understanding of likelihood, you have risk. When you have a little bit of ambiguity regarding these, you can be in uncertain territory or ambiguous territory. And if you can't assess at all what the possible outcomes are and what the likelihood of those outcomes are, you're moving forward generally in the dark. And it's hard to make an informed decision. And when we translate this to cancer care, some of the overarching themes are, what are the actual risks of an event taking place, like my cancer coming back? What are the chances of me getting treatment that I don't need? What are the chances of me not receiving treatment that could have potentially been beneficial? And then, of course, what are the chances of me dying of my cancer? And we have to synthesize this information along with what's an individual's tolerance of uncertainty and risk at the patient level, at the physician level, at the family member level, caregiver, and so on. And as I was preparing for this talk, I came across this book, The Art of Risk. It's a pretty entertaining read, kind of in a Malcolm Gladwell type of format. I would recommend it for anybody that's kind of interested in learning about, you know, how we're hardwired to think about risk. So with that introduction, I kind of want to jump right into what we do on the day-to-day as urologic oncologists and as physicians treating patients with cancer more broadly. And I want to start out with prostate cancer. Willett Whitmore, who is considered the father of urologic oncology, has a famous quote as it pertains to prostate cancer, where he states, "If cure is necessary, is it possible? And if cure is possible, is it necessary?" And I'll walk you through an example. So when a patient comes to see me with the new diagnosis of prostate cancer, as I mentioned, not all prostate cancers are imminently life-threatening. And people come in at various stages of life, you know, young people, good health, no other medical problems, to significantly older patients, a lot of medical problems. And I'm trying to make an assessment, or, you know, what are the opportunities for me to help this patient, and importantly, not to hurt this patient. And so the first thing I'll do is use a validated instrument. As you can imagine, there's lots of industries, life insurance, health insurance, that have a vested interest in predicting a patient's longevity. And so we go through this 8-page questionnaire asking about a patient's health. Do you have high blood pressure? Do you have cholesterol issues? Do you have any issue with circulation? Have you had blood clots? Information about family history. And then we also insert their cancer characteristics. You know, is this a cancer that was picked up with screening? Are there any evidence of metastases on CT scans or bone scans or MRI? Are there any evidence of lymph node involvement? Then we put in the grade and the stage of the tumor, and we get some output that looks exactly like this. And I'll just read this to you. So imagine that there are 100 men like you, the same age and overall health, and the same prostate cancer in terms of stage, grade, and PSA. If none of these men received treatment intended to cure their cancer, this is what we would expect to happen. So again, we have a 70-year-old man. If we did nothing at all with a kind of an intermediate risk cancer, at the 10-year mark, 65 men would be alive, 8 men would have died of untreated prostate cancer, and 27 men would have died of other causes. So this gets us to 80. In 15 years, now we're looking at 85, 12 men would have died of untreated prostate cancer, 47 men would have died of other causes. So just to kind of recap, at the 10 and 15-year mark, 8 men and 12 men respectively would have died of cancer, and 27 men and 47 men respectively would have died of other causes. And that's if we did nothing. Well, what if we did something? So if we did something, the most common interventions are surgery or radiation. You have about a 99% chance of being alive and not dead of prostate cancer at the 10-year mark and the 15-year mark. So that's pretty good. So why not treat everybody? Well, there's side effects. Cancer can come back, and after either surgery or radiation, there's real risks of being incontinent and leaking urine. And there's real risks of having fairly significant erectile function after this type of operation. And so armed with this data, again, I ask you, what would you do? You're 70 years old, you've got a kind of a intermediate risk cancer. If we treat you, your chance of dying goes down from 8% at 10 years to 1%, and from 12% at 15 years to 1%. And I'll just give you a few minutes to answer. Would you opt for treatment or would you opt for surveillance? All right, so here we have some results, and looks like about 1/3 of people would opt for treatment and 2/3 of people would opt for surveillance. So clearly no I guess we're in the midst of polling and interpreting poll results, but I think it's safe to say that there's no unanimous selection what everybody would do. Everybody approaches these types of numbers differently. And that's completely normal. That's completely expected. Now, this general concept that I've talked about really extends to all cancer types. This is not just prostate cancer, not just testis cancer. So if we focus on localized cancer, where we've got a patient that comes in, there's no evidence of cancer cells that have gone to other parts of their body, whether this is breast cancer, lung cancer, stomach cancers, colon cancers, brain cancers, you name it. So there's a diagnosis that's made. And at that time, we're trying to figure out if there's any evidence or any likelihood that there may be cancer cells that have already left the index organ, and would a patient potentially benefit from some type of therapy, generally chemotherapy or radiation, before removal or before any type of definitive treatment. And then once the index tumor has been treated, we're trying to figure out, is there any value or benefit in treating after that? And that's called adjuvant therapy. So before any type of intervention is called neoadjuvant therapy, and after is called adjuvant therapy. Now, if you were to have cancer cells that have left the organ of interest and we gave you neoadjuvant therapy or adjuvant therapy, you would have benefited. You would have been appropriately treated. However, if we gave you treatment that you didn't need, you would be overtreated and suffer the potential side effects. And similarly, if we didn't give you something that you would have benefited from, there are real risks of undertreatment. So keep these concepts in mind. And fortunately, for most common cancer types, we do have studies where we have large populations of patients, say 500 patients with prostate cancer. Half of them get some type of adjuvant treatment. The other half get no adjuvant treatment. We can tell you generally, who's going to live longer, who's got a less likelihood of their cancer recurring, but it's very hard to make that decision on a individual patient level. These are more population-based approaches. And now I want to, bring it into some of the research that we do for testicular cancer. Now, for a patient that comes in to see me with a testis mass concerning for testis cancer, we will get CT scans from kind of head to toe just to make sure that there's no evidence of cancer cells that have gone outside of the testicle. We'll do the surgery. Our pathology colleagues will look at everything under the microscope. And if they're considered low risk, they're at about a 10% chance of having cancer cells that we just can't see yet on a CT scan. And they have about a 10% chance of recurring. If they're high risk, that recurrence rate goes up to about 50%. So, if I'm sitting with a high-risk patient, I say, hey, there's about a 50% chance that removal of your testis was curative, and there's about a 50% chance that it may recur. And I would suggest that that is insufficient to make a decision at a patient level. And for an index patient like this, a high-risk patient who's got about a 50% chance of recurring despite negative CT scans, despite negative blood work, there are 3 options that exist. These are guideline options in the National Comprehensive Cancer Networks, the American Urology Association, European guidelines. Everybody gives you 3 options. One is surveillance. The second is a prophylactic cycle of chemotherapy. And the third is a prophylactic surgery where we remove lymph nodes that testis cancer tends to typically go. And there is absolutely no consensus on what the best option is here. If you go to Europe, they generally do a cycle of chemotherapy. Half the centers in the United States do the surgery. The other half advocate for surveillance. There's no consensus here. So let's, and just to kind of add to it, regardless of what you do, as I mentioned, testis cancer highly curable. The chance of being alive at 5 years is 99%. So that's a good thing. It's a good problem to have. So when we walk through these various options, let's start with surveillance. Well, the pros of surveillance is not invasive. There's nothing other than getting periodic CT scans, MRIs, and so forth. And if you were destined to be cured by removal of the testicle alone, you avoid treatment in half the patients. That's a good thing. On the downside, if you are to recur, generally you require 3 to 4 cycles of intensive chemotherapy, And this is, traditional chemotherapy with nausea, vomiting, hair loss, constipation, blood counts getting low, fevers. And importantly, in these young cancer survivors, there is about a 40% chance of having hearing loss, or some degree of hearing loss. They're at a 2 times a higher rate of developing significant heart disease, and they're at a 2-time higher rate of developing secondary cancers. So if you get it right, that's a home run. But if you get it wrong, there's quite an intensive treatment with it. Okay, so what about just doing 1 cycle of chemotherapy? Well, it's less toxic than 3 cycles of chemotherapy, if you would ever require that. And it decreases the chances of recurring from about 50% down to 1%. So that's good. However, half the patients that were destined to be cured with surgery alone are going to be overtreated. And most of the side effects for chemotherapy are dose dependent, which means that 3 cycles is better than 4, 2 cycles is better than 3, 1 cycle is better than 2, but it's still not zero. It's not zero. And we just don't have the long-term data to tell you what exactly the side effects are for these young cancer survivors. And this goes back to, a individual patient's tolerance for uncertainty about whether they have cancer present or not. The third option is surgery. It's called a retroperitoneal lymph node dissection, abbreviated as RPLND. And for this surgery, we can leverage the fact that testis cancer follows a very predictable pattern of spread in this area here that you see colored, but it's a big operation. Historically, it's done with an incision from the bottom of the rib cage to just above the pubic bone. We have to get all the bowel contents out of their way, and then we remove these lymph nodes. Now, the pros are you don't get chemotherapy, which is good. If you have cancer, yes or no, you're going to know for sure, so the patient has some certainty. It's therapeutic in the majority of time, so generally when you do this operation, it's curative. However, it's a major surgery. It's a big operation, and there are side effects. There are side effects you can see here that we're working around the kidneys, the main blood vessels of the body, the aorta, the vena cava. And importantly, the nerves that ultimately allow men to ejaculate are running right in this area. And sometimes men can have some serious issues and problems down the way with fertility. So, here we have these 3 options: surveillance, a prophylactic cycle of chemotherapy, a prophylactic pretty big surgery for patients that walk in with a 50-50 chance of having cancer recurrence. And again, I would ask you, what would you do? Would you go for a surveillance? Would you go for a prophylactic chemotherapy? Or would you go for a big surgery to potentially know if you have any lymph node involvement or not? So I'll just give you a minute to think about that and respond. All right, so we'll give it just a few more seconds. And so our results, it's a 50-50 split, 51-49. That sounds like some numbers that we've seen fairly consistently over the last week or so. So it's a tough call, and clearly no consensus. Half the people here want to keep an eye on things, half the people here want to do something. And I can tell you clinically, that's exactly what we see. Patients are like, "Doc, I need to know, let's do the surgery. Hey, I feel like I'm cured of surgery, let's keep an eye on things." And it's very much an individual decision. One of the few cases that it's very hard for me to tell a patient, "Hey, if this was me, this is what I would do." It's a tough call. Okay, so that's kind of the clinical problem. Now, what if we could do a little bit of a better job? Currently, we're at about a 50-50 coin flip. What if we could get closer to about 90% accurate? And now I'm going to kind of jump into some of the work that we're doing in our lab. And I want to give you just a very brief introduction to microRNAs. MicroRNAs are small non-coding RNAs that are involved in epigenetic regulation of gene expression. So these are small molecules that are helping our cells decide which proteins ultimately are going to be expressed. And for testicular cancer, over the last decade, there's been some exciting work, and a particular microRNA called microRNA 371 has been identified to be overexpressed in testicular cancers, which kind of fall into the family of germ cell tumors. And regardless of the type of testicular cancer, regardless of where of germ cell tumors that can arise in the brain, in the sacrum, kind of the tailbone area, there can be ovarian germ cell tumors, and and some kids have them as well as adults. Regardless of where they're coming from, men or women, this microRNA is overexpressed in nearly 90% of these tumors. And importantly, one of our collaborators identified that it's actually measurable in the blood. That a young kid with a germ cell tumor, they tested this blood. They pre-amplified the blood for this particular microRNA, measured it, and found that it's measurable in the blood. And so our group wanted to kind of look at, how does this perform in patients that have suspicious testicular tumors? So what we did is, for men that came in and had lesions that were suspicious for testis cancer, or perhaps they were getting a testicle removed for some other indication, we obtained a vial of blood immediately prior to their testis removal, and we compared the groups that ultimately were found to have a cancer versus those that had no cancer. And in our hands, the blood test, the serum microRNA 371, was more than 90% sensitive and specific for the diagnosis of testis cancer. And that was, clearly an exciting finding. Then, we started kind of thinking, well, what if we, so we know that if you come with a stage 1 tumor, like we discussed, a high risk stage 1 tumor, half of these patients are cured with their removal of the testicle alone. The other half need some additional treatment. And what if we could, do a better job instead of this 50-50 coin flip? What if we could get closer to a 90%, based on the work that we saw on using this microRNA test? And so we kind of modeled things. We have a patient that comes in with a stage 1 tumor, and if they've got cancer, residual cancer somewhere in their body, and they either get the big surgery or a cycle of chemotherapy, that's good. However, if we put them on a surveillance program and they ultimately end up relapsing, requiring intensive chemotherapy, that's going to be a bad outcome. On the flip side, if you come in with no cancer, if this removal of the testicle alone was sufficient, if we put you on a surveillance program, that's good. However, if you get a cycle of chemotherapy or the big operation, you would have been overtreated, and that would be considered bad. And when we actually looked at appropriate treatment using the standard clinical pathological predictors versus our microRNA approach, we increased the appropriate treatment from 50% to 90%. We decreased overtreatment from 27% to 3%, and we decreased undertreatment from 23% to 5%. So in general, we're treating the patients that want to be treated, and we're withholding treatment from those destined to be cured with removal of their testis alone. We also did some cost analyses and assigning a dollar amount to the various interventions. And across any scenario, more or less, we found that a marker-based approach would be cost-effective. Well, the next step was to see, how does this actually perform? So at our center, we have a multidisciplinary team with urologic surgeons, radiologists, medical oncologists, excellent pathologists. And when patients come in and they have early stage testis cancer, they have the opportunity to receive any of the guideline-directed interventions, observation, chemotherapy, or retroperitoneal lymph node dissection. So what we did is, for these patients that had their testicle removed and they were going on to receive a retroperitoneal lymph node dissection, we collected their blood serum immediately prior to surgery. We did a microRNA test on it, and then we sought to figure out, were we able to predict who is likely to have cancer after the surgery and who's likely to have no cancer. And when we looked at our results in a cohort of patients, we found that we're actually able to do a pretty good job. We were able to tell if you were likely not to have cancer at about 100%. we could positively identify the presence of cancer at 92%, and our overall accuracy was 96%. So, this was exciting, and this is a positive result. And just pictorially, you can see here again that we're highly able to identify who is likely to have cancer and who could safely avoid surgery. The next steps are to actually incorporate this into a clinical trial, and we're very proud that our institution is going to be the lead for a national study where after orchiectomy, now instead of going back and looking at the serum, we're actually going to run a blood test on these patients after their testis is removed. If there's no evidence of any positive miRNAs, we'll just keep an eye on these folks with the hope and expectation that they're destined to be cured by surgery alone. And if they've got evidence of residual cancer, we can offer them surgery or chemotherapy, and again, make sure that we're properly treating patients that would benefit from it and withholding treatment from those who would not. So this just kind of gives you a flavor of some of the precision-based approaches that we're taking here at UT Southwestern. Now, we've kind of spent some time talking about early stage disease, and we also see a lot of patients with advanced stage disease. And again, we're really happy to offer the full gamut of treatment options that are available. So broadly speaking, when you come in, here you can see a CT scan of a patient that's got fairly diffuse lung metastases. Then they get chemotherapy and we re-image them. In some cases, like on this top CT scan, you can see there's these huge residual tumors, and we've got to go in, we do these big operations to remove these tumors, and it can be a lot. They've had these cancers, they've had a reaction from chemotherapy. We're working around the big vessels. And in this top case, it's pretty straightforward. You've got to go in and you've got to do an operation. But you can also have CT scans after therapy where we have relatively small masses. And suffice it to say, we have no good way of identifying if those masses are likely to be residual cancer. And it's kind of convenient. The chances of either of those outcomes are 50-50%. So again, we find ourselves in a situation where the standard of care is to go in, do these big operations, but half of our patients would have never benefited. So this is, an area of research that we're very, very actively involved in. So, we go in, we do these big operations, and 50% of the time there's no cancer. And unfortunately, microRNA 371 does not really help in this clinical scenario. So we've been trying to crack this puzzle as well. And the first thing we did, we teamed up with some of our colleagues in nuclear medicine. There's some kind of new second generation PET scanners, and we thought, hey, maybe some of these PET scans have unique properties and characteristics that don't rely on traditional PET scans. Let's get PET scans on these patients after their chemotherapy and see if we can predict who's likely to have residual cancer and who's likely to have only dead cancer cells. So we tried this. We had 10 patients, small pilot study, and unfortunately, it really wasn't helpful. We found a couple of patients that we could accurately identify, but really not robust to make the individual patient decision. So we went back to the drawing board. We're like, well, microRNA 371 doesn't work, but maybe there's other RNAs that could be beneficial in helping identify who's got cancer and who's got no cancer. So this was work spearheaded by John Laffin, who is a PhD in the lab. And essentially, he identified two groups of men. Half of them had cancer at their surgery, the other half were cured. Did a screen where we looked at not just microRNAs, but all small RNAs. And we found 3 hits. And that was exciting. Maybe we're going to find some blood test that's going to help us identify who's got cancer and who doesn't. Unfortunately, we kind of did a little bit more rigorous testing, more due diligence. They didn't really pan out. You can kind of see here that these bars represent those with no cancer and those with cancer. They look pretty similar, so we didn't have a good discriminatory test. Well, not to be discouraged, we thought about what are other things that we can do here. And we leveraged the fact that we have a very robust collaboration with our UT Southwestern Shared Tissue Resources. It's an excellent group led by Cheryl Lewis and colleagues. And we collect cell-free DNA immediately prior to every one of these big surgeries. And essentially, as you can imagine, there's blood vessels that go into these tumor cells. Some of those tumor cells are going to shed DNA into the bloodstream. And now we're in the process of trying to figure out if we can use cell-free DNA profiles to identify who has cancer and who has no residual cancer. So that work is ongoing. Now, certainly it's exciting to think about these microRNAs as biomarkers, but well, here we have this molecular change that's seen in all testis cancer, ovarian germ cell tumors, pediatric germ cell tumors from different sites. And we know that, germ cell tumors, testicular cancers are exquisitely sensitive to cisplatin, more so than any other tumor. What does this mean? And do microRNAs have any potential role in this? So, we kind of went back to the lab and we tried overexpressing some of these microRNAs, starting out with 371, to see, does this impact the sensitivity or resistance to cisplatin? So we started out with 371, and the long and short of it was that it didn't. Well, then we thought, maybe the microRNAs are actually causing these cells to grow very quickly, and when cells grow quickly, they're actually more susceptible to chemotherapy. Is it possible that is being impacted by microRNA 371? And here you can see in a couple controls that these all basically change at relatively the same rate. So, nothing kind of super positive there. Well, microRNA 371 is part of a family of microRNAs, and again, an astute observation coming out of our lab. Maybe it's not 371. Maybe there are these other family of microRNAs that are involved. And we actually have, in just very early work, found that when we inhibit these other microRNAs, that we can impact the proliferation of testis cancer cell lines. So this is very preliminary work, but I hope it does illustrate how we're trying to identify biomarkers that can help us individualize treatment decisions, and also understand how these cancers progress, how they help them acquire unique characteristics, and how we can leverage these to do a better job taking care of patients. And as I mentioned, these are just ongoing efforts regarding the biological implications of altered microRNA expressions. So I kind of went through a whirlwind of prostate cancer and testis cancer and just gave you a glimpse of some of the decision-making thoughts and processes. But the take-home messages are going to be that cancer care is not a one-size-fits-all, and accurate patient-level risk stratification for appropriate treatment is mandatory so that we can avoid under-treatment and over-treatment. And novel means to risk stratify are mandatory to really accomplish this goal. There are too many people at UT Southwestern to make this happen, but I would be remiss not to thank John Laffin, Anna Savayeva, Bendu Kone, who are in the lab, and then our colleagues and collaborators, including Jim Amatruda, Matt Murray, and Jeff Gagan. Again, it's truly a multidisciplinary team. None of this would happen without them. And with that, I thank you for your attention. I'm happy to answer any questions. And by all means, if you have any questions that we're not able to get to today, please reach out. Thank you again.
Thank you, Dr. Bagrodia. That was fantastic. And we will jump right into questions. And actually, our first question comes from, I think, your lab. So Anna, you had some questions for Dr. Bagrodia. If you wanted to go ahead and unmute yourself and ask your questions. And just a reminder, please list any questions in the box so I can go ahead and call on you.
Okay. Hello, Aditya. Thank you for such a nice talk. It was great to hear an overview of testis and prostate cancer. So I would like to know actually a little bit more about who are in risk group, first of all. Maybe there are certain cohorts of people who need to be more attentive to their health, right? And the second, my question is, what are environmental factors, right? Maybe if we'll try to avoid them, there will be lower risk of developing either prostate or testis cancer. And then maybe there are certain strategies that could be implemented in order to, again, significantly decrease the risk, at least for people who are in risk groups. Like some more information on that, I think, would be helpful to know.
Sure.
Thank you.
So maybe starting with prostate cancer, high-risk groups, you know, we're learning more and more about genetic predisposition syndromes. And some of you may have heard of BRCA mutations, which are typically associated with breast cancer and ovarian cancer, but it actually turns out that a significant proportion of men with prostate cancer are going to have BRCA mutations as well. So the first major risk factor is going to be a strong family history, not just of prostate cancer, but breast cancer, endometrial cancer, lymphoma, leukemia, pancreatic cancers. And if any of this sounds familiar to your personal family history, you know, it's probably worth letting your primary care physician and urologist know. The second major risk factor is going to be African-American ancestry. And generally there's about a 1.5 time higher likelihood of developing prostate cancer among.
Dr. Bagrodia, I'm going to interrupt you for 1 second. If you could just talk up just a little bit from when your presentation ended, you got a little quieter.
Okay, sure.
Thank you.
I'll get a little bit closer. Are you able to hear me now? Okay.
Yeah.
So I'm not sure where it got a little bit light, but the two main risk factors are going to be family history and then African American ancestry. In terms of environmental risk factors, Anya, we don't have a great sense of this in terms of for prostate cancer. There are some associations, but it's not really been developed into a causal relationship. For testis cancer, it's going to again be family history, a history of an undescended testicle. Those are going to be kind of the tried and true bona fide risk factors. The worldwide incidence is rising. It's rising highest among Hispanics. And there's not been a causal agent. There's all types of theories. Cell phone use, laptops have been potentially implicated. Marijuana use is something at kind of high doses has been fairly significantly associated with testis cancer. In terms of prevention, you know, testis cancer is rare enough where nearly certainly it wouldn't be cost effective to implement widespread prevention strategies. For prostate cancer, there have been large scale studies, including medications which can kind of shrink the prostate, such as finasteride and dutasteride. There are studies of various vitamins, selenium, lycopene, vitamin D, and suffice it to say that those have generally been negative. At UT Southwestern, we do have some studies actually looking at compounds such as curcumin, which is a high-dose turmeric derivative, to see if it can actually prevent cancer progression in men that are being observed, and to see if it can prevent recurrence of progression in men that have been treated for prostate cancer.
Great, thank you. Before I move on to the next question in the box, we did receive an emailed question that kind of plays into what you were just talking about. Are there any diet changes or wellness tips to promote prostate or testicular health that have been proven?
Sure. So, you know, again, there's never been any definitive study suggesting that that any types of medications, vitamins, food groups are going to be preventative in terms of cancer development. Antioxidants broadly appear to have some anti-neoplastic properties. There's actually been quite a bit of research into pomegranate derivatives, nothing definitive there. Lycopene, so fruits such as tomatoes, nothing definitive there. I think like most things, a moderate, healthy lifestyle and diet is going to be your best option.
Great. Our next question comes from Araceli Reyes. You had a question for Dr. Bagrodia. Go ahead and unmute yourself. Just a second. Okay.
Hi, Dr. Bagrodia. I just had a question. My husband has a strong family history of prostate cancer, and he was diagnosed with a T2 stage prostate cancer a few years back in 2016. We have a son who is now in his 40s, and I'm just wanting to know what would the ideal age be for him to be followed with, you know, or begin being followed for possibility of, you know, early stage prostate cancer, or and what age will the PSA be recommended for someone like that, as insurance is not very open to accept him getting a PSA this early on?
Sure. So, great question. And the bottom line is, so for a person without a high risk of developing prostate cancer, generally the guidelines recommend screening between the ages of 55 and 69. And that's going to be a shared decision between a patient and their physician, whether it's their primary care physician, if they feel comfortable, or certainly a urologist. When you get into risk factors, including a strong family history, the guidelines are not quite as clear. The lowest ages would be 40. Generally, most guidelines fall closer to 45 or 50. And suffice it to say, in terms of hardcore evidence, there's never been a study of patients with a family history. Half of them got screened at 40 versus 45. They got followed out, and group A or B lived longer. And likely that's never going to happen. Generally, I would say the majority of guidelines say right around 45 to 50 years old.
Great, thank you. And going to another question before I move into the box, based on what you just said, when is it recommended that someone should see a urologist versus just talking to their primary care physician?
Yeah, it's a good question. And certainly there are primary care physicians that are very, very well-versed in the nuances of PSA screening and prostate cancer screening. The guidelines, explicitly state it should be a shared decision-making approach. It shouldn't be reflex. I generally, discourage going to screening fairs or anything like this where there's no conversation. You're getting a blood test, and now you've got this information that you've got to kind of deal with. Generally, I would say talk to your primary care physician, and if they don't feel comfortable with it, by all means, you should probably have a discussion with a urologist.
Great, thank you. Our next question comes from Bharath. Bharath, you had a question for Dr. Bagrodia? Give me just a second to unmute. There we go. Bharath, can you hear us? Do you want to go ahead and ask your question? Oh, not able to unmute and speak. Okay, so I will go ahead and ask Bharath's question. So we want to know, is some of these treatments that you talked about, some of these screenings, is this applicable to other types of cancer like breast cancer?
Sure. So the short answer is yes, we're doing a better and better job of screening smarter. And maybe I'll start out with kind of the story of prostate cancer. So 10 years ago, if you got an elevated PSA, and this was maybe just more a reflexive test that was being done as a part of your annual blood work, you would probably see a urologist and you'd probably be advised to get a biopsy. Now, certainly at UT Southwestern, if you had an elevated PSA and you came in to see one of the urologists, before reflexively performing a biopsy, nearly certainly we would work with our colleagues in radiation oncology, and get an MRI of the prostate. So we're going to get an understanding of, are there lesions that need to be targeted? Is the prostate stone cold clean? Is it normal? And of course, you take in the patient level factors as well. And many times we can safely avoid a biopsy. And on the other end of the spectrum, instead of going in blindly and poking, we can actually make sure that we're targeting areas that are suspicious. Not only can we do it kind of merging images, we also offer something here that's relatively unique, where you can actually get a biopsy in the MRI scanner, visually confirming that the lesion of interest has been sampled. So in prostate cancer, that's going to be an example of how we've taken this kind of shotgun approach to a very much more of an individual tailored approach. And that's just in terms of screening, not even getting to a diagnosis. Breast cancer, to be perfectly honest, it's not my area of expertise, but we are, there are efforts going on the breast cancer screening side. We actually have screening studies underway, again, to try to really understand who needs a biopsy or further investigation, who's got imaging findings suggestive of a benign process, then who we need to be more aggressive towards.
Thank you. Our next question comes from our good friend, Dr. Stu Ravnick. Dr. Ravnick, you want to go ahead and unmute yourself?
Thank you. Hey, Aditya, nice work. Great to see you. Good to see you carrying on the great work of Jim and Ganesh Rajan, Ujas Gramanas, and the whole crew over there in urology. I'm really excited. Just so many questions. Testosterone, men's health, metabolic syndrome, the whole range of ways that we can promote men's health and knowing what's going on. But I want to go to the results that you had in your lab. You said a couple places that mirrors the mRNA, microRNA is showing positive results in all of the samples that you took, but then you said it's not helping. Can you kind of give us a little bit more update on that? And please join the graduate school so we can get some grad students in your lab.
Yeah, thanks, Stu. And so it's a little nuanced. You know, germ cell tumors, testis cancers are fascinating tumors. They're kind of heterogeneous, part and parcel of them. And the chemotherapy is generally very effective against all histologies except for one particular subtype. Teratomas are kind of a cousin of testis cancers, and they are testicular cancers, but they're the one histology that's resistant to chemotherapy, and they have to be cured surgically. So if you can imagine, a lot of times you have these mixed tumors that have metastasized, you get chemotherapy, all the non-teratoma has been eradicated, and all the non-teratoma is what expresses microRNA 371. Now you're left with about half the patients that have teratoma, and suffice to say that we don't have a biomarker for teratoma. So it's absolutely getting into the weeds. It's a very astute observation, but yeah, that's kind of, you know, the holy grail. I mean, certainly from my perspective, when we do these big operations and it's all dead cancer cells, you know, of course it's good in terms of the patient's likely to be cured, but the only way to verify that is through a relatively large operation.
A prophylactic collection of gametes ahead of any treatments, so that if a couple does want to have a child, that they can have that as an option.
Absolutely, absolutely.
Thank you. Our last question before I pass back to Jenny to close us out is, how has the public campaigns of men's health awareness, including Movember, changed how men approach their health? Have we seen an increase in an active approach to men's health versus the kind of passive approach we got in older generations?
Yeah, so maybe I'll start with the area that's you know, that I'm least familiar with in terms of treating, and that's going to be, you know, men's mental health. I think anxiety, depression, the destigmatization of those very, very real disease states is an active process. You know, men seeking counseling, certainly something I ask patients about that are going on medications, dealing with cancer diagnoses, that, hey, is there somebody you want to talk to? Let's get you to be a part of a support group. Generally, urologic cancers are going to be, you know, more sensitive cancers. And for testis cancers, it's well known that there's delays in diagnosis. You can imagine young children, young kids, young adults don't have anybody. There has been some progress. There's not screening for testis cancer, which is, you know, contentious and debatable. But for prostate cancer, mostly because it's so common. I mean, I would venture to say that everybody on this call knows somebody with prostate cancer. And now people know their family histories. It's not like, yeah, you know, we didn't talk about cancer, that. So we're making strides. Now you compare it to, you know, women's health, breast cancer, Susan G. Komen, and, you know, these amazing, super large, well-organized organizations. There's still a lot of work to be done, but, you know, making progress year over year.
Great, thank you so much. I'm going to go ahead and pass back to Jenny to go ahead and close us out.
Thank you very, very much. Those were terrific questions, Dr. Bagrodia. We appreciate you so much for joining us. We're really excited to learn about these advancements in men's health and encourage everyone to get involved in Movember awareness. I thought that last question was really on target. Thank you, Corey, for always being our tech guru and for moderating Q&A. And to everyone who joined us this evening, thank you so much. As always, look for an email tomorrow or super soon thereafter. It could be Monday with a brief survey about tonight's program. We really value your feedback. We will be taking a short break for Thanksgiving and we'll return on December 3rd with the next Science Cafe featuring Dr. Jacqueline Albin and the science of food. And she is just as phenomenal as Dr. Bagrodia. In fact, they both received an award last year called the Clinical Excellence Award. And I was frankly blown away by just how humble they are and also brilliant. So I really look forward to the next Science Cafe as well. Let's see, Dr. Alvin, she'll be discussing the emerging field of culinary medicine, providing tips and guidance for healthy eating during the holidays. That's what happens when you go off script. Finally, we will be launching a new clinical health education series next month called The Insider's Guide to Healthy Living. So be watching your email for information from us in the coming weeks for additional information. And we do hope you'll register and join us and tell us what you think. We're calling this a soft launch. We're really excited about it, but we want to make sure it meets the needs of the community. As we close out tonight's cafe, from all of us at UT Southwestern, please continue to wear your mask. Maintain that physical distance when you're in group situations and practice good hand hygiene. We are at a critical moment and we need your help to stay healthy. And for now, we wish you that good health. We wish you good spirits and a good rest of your evening and happy, happy Thanksgiving. We are adjourned.